Thank you very much for joining us in the session on family planning. I would like to introduce our chair. She is Grace, and she has been the Dean of Faculty in Social Science in FC College, and also head of the department in Fulbright Scholarship, Mr. Ibrahim. His paper is on Bayesian small area estimations of contraceptive prevalence in Pakistan, district level CPR and MCPR from proxy administrative data. He is a research and policy specialist in research and development solutions, Islamabad.
Thank you. I'm Mohammad Ibrahim and I work as a research and policy specialist at RAGS. Our basic work has been in recent past over the small area estimates, and this one we have done for CPR and MCPR in Pakistan at the district level. So basically CPR has been stagnant over a decade in Pakistan, and the main reason that we figured out was that we have the estimates for national and provincial levels, however the estimates for district level are not present. And there has been literature showing a lot of disparities between top tier urban areas and rural areas. Hence we tried to use a methodology where we computed the district level estimates, and which we consider that these will be necessary for target resources and outreach and other supply chain programs which policymakers can use for the better outcomes for the contraceptives. Among the data gap, we found out that PSLM along with PDHS both provided provincial level estimates for contraceptives. Another source was PSLM that was at district level. However, this data source did not have any family planning section within that data set. And there was available, CLMI's data is available from the program data which the government and private sector collects about their contraceptives, which are dispensation data is available. And however, this data is not considered credible by many scholars because it has incomplete reporting rates. Sometimes the debate is on dispensation, doesn't mean that consumption is actually happening for the contraceptive. And there is inconsistency within data where consumption is high, stocks are low, and other errors. So hence we use these, our main idea was to use these sources to compute district level estimates for CPR and MCPR. So here again we had the provincial CPR and MCPR benchmarks from our PSLM 1819. We had annual data for contraceptives at the district level for the users, which we computed from their dispensation data from CLMIs. Census gave us the Mavra data for all the districts in Pakistan. And PSLM 1920 was used as our independent variables, for the independent variables, where according to the literature, these were the 5 main independent variables that we required to estimate how much contraceptives each district might have been, the Mavra in each district might have been using. So again, our approach was using these 4 data sets and converted the methodology into 2 parts. The first stage was mainly to compute the crude estimates, which was used according with the CLMI's data, the provincial estimates that we have, and the census data that we had. For our second stage, we incorporate these crude estimates in the Bayesian model along with the PSLM 1920, where independent covariates were used to estimate the proper Bayesian estimates. So in the first stage, CLMIS gives us a consumption data which we converted into users by using the conversion factor, and then we calculated each district's users and calculated the users per Mavra in each district. Again, we did the same exercise for each province as well, and then we found out the relative deviation from these districts. And then after that, this deviation was multiplied with the CPR rates that we had from the PSLM data 1819 and this gave us the crude estimates for our next stage. An additional thing that we did here, the survey data and the district estimates, these two are different sources. So our standard errors included from the survey data as well, the provincial one, and district estimate standard errors were included in the Bayesian model itself, where it was important to know how much confidence interval we'll have for each estimate. Our predictors came again from the PSLM 1920. Education index and income index were computed through the UNDP methodology, which is using Human Development Index. Total fertility was kept for 25 years old because this was important according to literature, that the fertility under the 25 years old is important for future predictions. Agriculture share showed us which districts had more remote areas compared to urban. Manufacturing share showed that urban areas are there more compared to the agriculture. Proxy was used as well for our estimates, which I will explain later, which is the users per Mavra as a weighted for each district. And provincial effects were again taken from PSLM 1819. So our model was basically a logic model because our estimates were from 0 to 1, and we used this as a distribution for our estimates. Second, we kept the provincial effects jointly computing a bivariate model where CPR and MCPR were correlated and their standard errors were correlated to estimate R, so that MCPR is not separately calculated, rather it remains under the whole model. Second, our proxy model was used to correct our biases. So the provincial weights that we have already in the model, the convergence, when the Bayesian converges to estimates converge, they don't fall very near to the provincial estimates. That was done using the proxy model of users per Mavra. The Mavra, as we did not have any other source to estimate the district variation in the data. Second, there were PSLM, CPR, and MCPR were anchoring estimates, which for each province a different estimate was used, and the variation of districts were revolved around those estimates. Second, firstly, again as it was a bivariate model, the MCPR was kept at 0.7% of actual overall CPR. This was computed using, after understanding the data that we had from PSLM. The provincial estimates showed us that MCPR is always 70% on average, lower than overall CPR. Secondly, our directional effects were the estimates that the independent variables that we had, their relations were set as a prior information in the model. Education was correlated as a positive one, income as well, and manufacturing share in urban areas are positively correlated with CPR. Agriculture share and fertility were negative, and these were strictly conservative effects. As fertility is high, CPR levels will be low. Lastly, proxy model had also been incorporated in this to determine our error rates in the CLMIS data. In this, agricultural areas, rural areas mostly have higher reporting errors, so hence we incorporated that, and industrial areas, the urban areas usually have lower error rates, so we had a negative sign for that in the model. Our internal checks were important. All our estimates of MCPR and CPR met the constraint that we had set, and our bounds internal confidence intervals will be discussed later. And lastly, our external checks were important to validate our estimates. Here is the distribution of our crude estimates and the Bayesian estimates. Crude estimates coming from the first stage, and the Bayesians were the refined estimates that we got. We can see that the crude estimates had a lot more variation in the data, and the Bayesians one, when they converged properly in the model, the estimates variation was reduced. Here, our confidence intervals were within the range that is accepted in the international standards. It's considered that if the mean value is under 10 percentage points, then it's better, it's a good model. So our, on average, our percentage points of confidence interval was 6.8 for CPR, 5 was for MCPR, and we also, internal assessment was to check whether if we combine all the district estimates, the users in all the districts, whether against SMAVRA, whether the estimates are close to the PSLM, CPR and MCPR, and we could see the percentage points difference has been within under 1 for all the provinces. Our external validation was to find the literature which computed their own district level estimates, and we found 12 recent studies, out of which 8 were within our range, under a difference of 5 percentage points. 4 districts were more than 5 percentage points, which sort of tells us that our estimates are more or less very robust, and for few districts which are at the bottom, the 3 districts, we couldn't find the recent literature for these ones. However, our past literature showed us that our estimates are very close to what they had predicted in the past. This graph shows the CPR levels. Again, PSLM had a higher CPR level for Punjab compared to other provinces, and Balochistan was the lowest. We can see that variation within the provinces, that and in South Waziristan area, the CPR levels are low. Again, the disparity is quite similar. Urban areas, Punjab, the North Punjab and Central Punjab are performing better compared to the South. In Sindh, Karachi and Hyderabad are performing better compared to other interior Sindh. Balochistan is overall not performing well. Even Quetta is quite low, their CPR. And in KP, we can see that the districts near to the Afghanistan have been not performing as well as the other districts which are closer to Punjab. Similar variations were seen for MCPR. Model contraceptive was more performing, there were more users in the urban area compared to the rural ones, and similar patterns can be seen as the overall CPR. So basically our estimates through the internal validation and external validation are robust, and these can be used for the policymakers to identify district which needs targeted intervention. And these estimates are using a lot of, as shown, the 4 data sets. And these estimates doesn't require a high cost. And in the international journals, we can see that the small area estimations have been picking up attraction, because these estimates show how policymakers can target each district. Even granular level at the sea level, these can be computed. And thank you.
Thank you. Our next presenter is Dr. Shukriya Khan. She is Provincial Advocacy Coordination Office in RIS Consulting. She will present on client's experience, acceptability and satisfaction with self-injection.
Thank you so much. Assalamu alaikum. And I would like to tell my name again. It's Dr. Shukriya Kiran and not Dr. Shukriya Khan. So the study which we conducted was on client's experience acceptability and satisfaction with self-injection DMPA-SC affecting continuation and autonomy in District Ghotki and Kurangi, Sindh, Pakistan. Before I start with my presentation, I would like to orient you all with DMPA-SC. It's a 3-month contraceptive injection. It is used subcutaneously. Females can use them by themselves. It's easy to use, 99.9% effective, and it empowers female and also promote agency. So the contents that will be covered in my presentation includes introduction, methodology, summary of results, conclusion, recommendations, and acknowledgements. So currently Pakistan's population is 241.5 million and it has a high fertility rate of 3.1. That is 3.6 child per woman. Sindh has been emerged as national leader for the scale-up of DMPA-SC-SI as a part of Pakistan's FP 2030 commitment. Just to ensure that, they have also committed Sindh Population Policy 2016, in which they have agreed to commit towards a CPR of 45% and to reduce fertility rate to 2.1%, one child per woman. DMPA-SC has also been introduced in the costed implementation plan for the same purposes in Sindh in 2015. DMPA-SC is a drug which I have already introduced, so I'll move to my next slide. The study objectives include assess client's experience, acceptability and satisfaction with DMPA-SC self-injection, including ease of use, continuation and side effects. It also explores urban-rural women variation in access, providers support, follow-up and availability of take-home doses. It identifies challenges and enabling factors influencing the adoption and continuation of self-injection. It also generates actionable recommendations to inform strategic scale-up of DMPA-SC-SI services in Sindh and future expansion to ICT, AJK, Gilgit-Baltistan and Balochistan. So the study employed a desk review and qualitative research designed to generate practical in-depth insights into women's experience, perceptions and satisfaction with DMPA-SC. Desk review included 10 documents, which includes DMPA-SC as a promising approach to improve contraceptive continuation, acceptability of self-injection of DMPA-SC in Uganda and Senegal, WHO Self-Care Guidelines 2019 and updated 2021, Government of Sindh Population Policy 2016, Costed Implementation Plan for Family Planning Sindh, which was from 2015 to 2020, Randomized Control Trial Report by Government of Sindh, Key Learnings from the Pilot of DMPA-SC Self-Injection, National Policy Landscape Analysis of DMPA-SC and Self-Injection in Pakistan, and DMPA-SC Self-Injection Rollout and Scale-Up Plan 2023. Not to miss, DMPA-SC Training Manual Population Welfare Government of Sindh was also included. Study sites, so basically 2 contrasting sites were used. One was urban and one was rural. For urban, Karachi, Kurangi, RHS-A was selected, and in rural, Ghotki, Obaro, and 30 THQs were selected for interviews from the clients. The reason to keep these 2 variations was to channelize the socio-economic difference and also the difference in digital literacy and the literacy of females. Data collection was done through IDIs of 23 women, out of which 14 were in Ghotki and 9 in Kurangi. The interviews explored the females who used self-injection on motivation, acceptability, ease of use, challenges and continuation, while the FGDs were conducted with LHWs, the providers, who were explored for experience, supervision, counseling, follow-ups, and programmatic gaps. For ethical consideration, informed written and verbal consents were taken. And for data analysis, thematic analysis was used through Excel with coded data. So when I come to the summary of results, in this section I will be presenting the insights from clients and healthcare providers in Ghotki and Kurangi on the use of DMPA-SC self-injection, highlighting their experience, challenges, and contextual shaping adoption. First point that we will be covering is client knowledge and satisfaction. High comprehension after counseling. So it was seen that as good was the counseling was from the provider, it really helped the females adapt to it, and their knowledge helped them increased with increased knowledge is equals to was directly relating to the satisfaction. Hands-on practice was also a factor that increased their confidence, as dummy models were given to the providers for them to practice on, which increased their confidence to adapt to this commodity. And strong satisfaction was also seen because of the privacy and convenience the drug offers. Acceptability and preference. Strong preference over pills and I would like to add the statement from one of our clients from Obaro, which said, the health workers explained everything clearly and guided me well on how to administer the injection, which further was a reason she was happy with the drug. Acceptability and preference. Strong preference over pills and IM injections was noticed, and the drug also gave fewer side effects and greater autonomy. Peer influence was also one of the reasons for adoption, because ladies were more convinced when their friend user asked them to use. So I previously used, one of our clients mentioned that I previously used oral contraceptives, but they caused discomfort, so I switched to DMPSC injections, which are much more convenient. And one of them also mentioned that I recommended it to my cousin because she struggles to visit the clinic regularly. This method gives her more freedom. So when I talk about privacy and autonomy, since the medicine can be used by yourself at an area where you're convenient, where you feel safe to use, so it had more privacy, value and discretion control, and it also needed less visit to facility, which also somehow helped them with the economical, the money they use for the transport, etc. And family support also enhanced their comfort. So this method, one of the clients from Turkey, Gotki, mentioned that this method is much easier and does not require health facility visits. I'm confident now and can administer it at home in privacy. And one of our provider, LHW from Turkey, documented that the clients were very satisfied with this injection because they can administer it at home without spending money and time in travel. Definitely for ladies who are living in remote areas and those who doesn't have their, I would say, family or relatives is living close by, it was a very convenient drug for them. Monitoring of side effects and its management. So minor side effects were reported, which included irregular bleeding, slight weight gain. But this did not affect the continuation of their use. One of the clients also mentioned that because we were so well counseled by the LHW, the provider, it really gave us that confidence and we were ready for any type of side effects which were told by her. So this really helped her in continuing the usage of the drug. Health worker guidance supported continued use. So one of our clients from Korangi documented that the nurse explained that some women experience spotting or changes in their cycle, but it hasn't affected me much. And similarly, another client from the rural area, Turkey, documented that I was informed that I might experience minor side effects such as irregular periods and weight gain, but I did not face any significant use. So also a mental counseling का जो हम लोग aspect इसमें कहते हैं कि preparation really helped her to accept the upcoming side effects. Safe disposal practices. Talking about this, safe disposal of used syringes remained a challenge. Clients and some providers lacked clear knowledge of correct procedures. Need of visual aids and simple disposal guidance is still required. So one of our client from Turkey stated that at first I threw the syringes in the trash, but later I realized that was not the right thing to do. So I returned it to a lady worker. And similarly, another client from Turkey, Obaro Gotki documented that I bury the syringes in the ground, as I feel it is a better alternative rather than throwing it away. Social, cultural, and gender dynamics. So when this drug was introduced, family support and cultural norms really influenced the adoption. But women showed varying levels of decision-making autonomy. Many consulted spouse, while others acted independently. Women promoted the method and encouraged. So a positive result was seen. At first, I was hesitated to tell my husband, but after I explained him how easy it is, he was supported and encouraged me to continue. This was a statement given by an urban client in Korangi, while from a rural client it was mentioned that in our community, it is common to prefer methods that do not require frequent visits to the clinic. So वो जो एक cultural हमारा है कि female जा रही है बहबूदे आबादी के office में, तो उसमें वो वाला जो एक barrier है, that was addressed through this medicine. What were the key learnings from this study? So we'll one by one cover them. First, which we was known and which I have been also mentioning in my results, was client empowerment, autonomy and acceptance. So urban-rural disparities require tailored approaches. So why are we calling it as a tailored approach? Is because urban people have more education, have more facilities and a better transport system to go to facilities. But when we talk about the rural infrastructure, it has to be a more of a outreach strategies will be required to address those matters. Training, counseling and health worker support were foundational. Reliable supply chains are essential for continuity. Women in rural high temperature areas face difficulties storing DMPA-SC at home, because of which few also asked the lady health worker to keep it at their home if they have a safer space to ensure that the temperature that is required for the medicine is there. Side effect management and follow-up support really help them because of the immediate availability of LHWs, and family and community support is a detriment of success. System integration and policy implementation needs strengthening. Despite all these services are being given, the indicators are yet missing in LHW, MIS and DHIS-I2 as well as one more, CLMIS, yes. Peer advocacy can drive demand if strategically supported. So there were also few recommendations that were, taken out from the study, which included health system level while program level recommendations. The health system level recommendations included strengthened training and SI guidelines implementation in terms of safe disposal, in terms of, temperature management and keeping of the drug. Enhanced provider support and supervision across all levels, strengthened client tracking and data systems, improved supply chains and stock monitoring, expand access and promote equity in rural areas, expand take-home dose availability, standardize side effect management, promote safe disposals, improve safe storage, and monitor and evaluate program implementation. When we talk about the program level recommendations, it includes enhanced community engagement, engage families and communities, dispel misconceptions with trusted voices, and drive demand through behavior change. So we can say that DMPA-SC-SI empowers women since it can be easily used in the remotest of the areas. It enhances convenience, privacy and continuity. It has strong potential for national scale-up. It requires system strengthening and continuous support. These are some of the photos that were taken during the interviews. And my special acknowledgement is to Population Welfare Department, Government of Sindh, for their leadership and institutional support, especially Mr. Hafiz Saab, Dr. Nariman, Mr. Shah Faisal Saab, and Dr. Shama. And from Costed Implementation Plan, Dr. Talib Lashari for his technical reviews and guidance. From the Department of Health, Sindh and RMNCH for their continued support and technical inputs, Dr. Farhana Mehman, Dr. Kashif Khanzada, and the study participants, which were the women from Ghotki and Korangi, for sharing their experience. District management and field teams were included PWD, RMNCH, family planning providers, LSWs, while from Risk Consulting Research Team, Dr. Samira Rizvi, who was our lead consultant, Dr. Fazal Rafe, and I will just take few quick names, that is Shaukat, me, myself, Dr. Maria Sarmad, and from Bill and Melinda Gates Foundation, who funded the study, and especially our Risk Consulting FP Management Team, Mr. Sajad Saab, Roshan Fida, and Amanullah Saab. Thank you so much.
Thank you very much. It was a really interesting study. But we will also like to have some quantitative view of this area, that how much people are using this contraceptives and what is in-depth underlying reasons you have given, but we would like to know that how many people are using this method. Now I would like to invite Dr. Javeria, Ms. Javeria from research organization. It is from White Ribbon Alliance, and she is Assistant National Coordinator, Forum for Women Development. She will deliberate upon what women want and how fertility family planning is in Pakistan.
Good afternoon, everyone. Thank you for joining the session. Today's presentation highlights the voices of women across Pakistan who shared their most urgent needs related to reproductive and maternal health. The work was carried out by the Forum for Women Development and Research as a part of White Ribbon Alliance. I will now walk you through what women shared, why family planning remains a critical issue, and how these insights can guide stronger policies and services. So it all started in 2019 with What Women Want campaign. We have 1.2 million women globally, including 250,000 women across Pakistan, were asked one simple question: what is your top priority for your reproductive and maternal health? The strength of the campaign lies in asking and listening to women directly instead of having predefined answers or predefined notions in mind. So their responses truly point us toward the real gaps and the change they expect from the system. So these are the top 10 demands raised by women, with family planning emerging as the strongest. The most themes reflect the daily challenges women face, from access to information and respectful care to nutrition and reliable FP services. Together, these demands show where the system is functioning and where important gaps remain. So why family planning is a critical issue in Pakistan? It's not just a health issue, it's a development issue. Pakistan high population growth rate places pressure on health, not only on health system, but it has really choked the education and economic system as well. So modern contraceptive use remains low, and unmet needs continues to be a major cause for unsafe abortions and maternal health risks. When women cannot access FP services, the entire system carries the burden. So why family planning requires urgent action in Sindh? So in Sindh, family planning indicators also show really slow progress. CPR has increased marginally, only marginally, but many districts, especially the far-fetched areas, really lack the consistent contraceptive availability and trained providers. So why we chose Sindh? Because at the same time, Sindh has a very supportive policy environment. Also, half of our responses for What Women Want campaign were from the Sindh. So this created a timely opportunity for us to act, especially when women themselves have clearly identified for us what they need. So our study had two goals: to understand women's real experiences and unmet needs related to FP. The second one was to translate those women demands into practical, actionable solutions for government and our development partners. So the intention was not just to gather data, but also to create a pathway for these voices to shape policy. So our methodology first included the analysis of the FP demands. We collected over 100,000 responses from women across Sindh. The second one was we conducted 2 provincial consultations. One was with the development partners and the other was with the government official. And the third, simultaneously, we had 2 listening sessions with the decision makers and also the women. So first, the responses collected from women across Sindh were all open-ended responses. So we use inductive reasoning, meaning that the themes emerged from what women said, not the predefined or pre-designed categories. So then our global secretariat used AI models and detailed and in-depth analysis for them to create themes out of these responses. And then the responses were compared with the existing literature review and the known service delivery gaps so that we could validate and contextualize our findings. So basically these women demands were fell into 4 major categories. The first one was information. Women wanted clear information regarding contraceptive methods, how to use them, what were their side effects, and how to involve family members. Second one was availability. They wanted trained providers and reliable contraceptive stocks. The third one was accessibility. Women wanted services closer to their homes and also ideally free of cost. And the fourth major one was quality. They wanted respectful care, proper counseling and follow-ups. So basically they highlight that FP challenges are not only about supplies, but they are also about knowledge, trust and service quality. In the next phase, we held 2 provincial consultations, one with our development partners and one with the government departments. The goal was to validate women's demands, gather expert input, and explore policy and governance solutions. So it really helped us in aligning the development partners and multiple stakeholders around a shared vision. So what they did, the stakeholder emphasized the need for women participation and community engagement and citizen oversight, and they acknowledged the governance gaps in weak accountability and poor coordination between departments. So a consensus on recommended actions emerged. This ranged from improved FP knowledge through behavior change communication, engaging men and families, strengthening access and availability for women's contraceptions, family planning methods, and creating mechanisms for women feedback and accountability. So all groups agreed that women voices must drive future FP reforms. Then 2 listening sessions were held in 5 districts of Sindh. These sessions created direct communication between the decision makers and the women, and also the identified district managers were from Department of Health, Population Welfare Department, LHW program. So women identified their challenges, they also identified the solutions and then conveyed it to the decision makers. So what happened was that actual improvements were made at the spot. So when women identified their solutions, the district managers became more aware of their issues. So that increased the coordination between the departments. Severe immediate improvements were made, such as retraining of HWs, arranging FP camps, improving service delivery, and creating simple information brochures. So that demonstrated the power of women's participation in improving FP services. So what we achieved through our campaign was that first, women voices were institutionalized. The listening session model was added to the FP 2030 PC1. That means that it will continue with the government funding. Second, we secured a 5% increase in Sindh's family planning budget despite COVID-19 at that time, raising it from 4.7 to 4.97 billion rupees. Third, we developed a policy paper called Women's Voices for Better Choices to guide policy makers and with our clear demands and solutions. And lastly, Sindh model gained national interest. A technical working group on family planning was formed to support replication in other provinces. So basically, our campaign highlighted how family planning emerged as a consistent and strongest need among women. So their voices highlighted the gaps and also provided the solution to access these gaps. So by creating direct dialogue between the decision makers and women, the project delivered quick improvements and built trust in the system. Most importantly, it has paved way for the future work, showing a practical, low-cost model that can guide stronger FP policy and can be scalable and expandable to more districts and provinces. Thank you so much.
Now, last but not the least, I invite Dr. Adnan Khan, Chief Knowledge Officer from RATS. He will deliberate upon his paper.
Thank you, Dr. Aisha. I'm just going to introduce the subject. Basically, family planning is, in 2025, we all know that family planning is a useful and beneficial and cost-effective investment. From very old work like Guttmacher showing every dollar invested yielding about $2.2 saving in maternal health, to about $17 in somewhat wider health education by the UNFPA. Our own analysis in 2013 showing about $20 saving in health, environment, and wash costs. So, without further delay, I'm going to pass on the presentation podium to Dr. Aisha Iram, who's a PhD economist and econometrician who's done most of this work. Thank you.
Thank you, Dr. Aisha and Dr. Atan. I'm Dr. Aisha Iram from Research and Development Solutions, and I'm pleased to present today our analysis on the economic costs of unintended pregnancies and the returns we can get from investing in family planning in Pakistan. So why this issue matters? Why the issue of unintended pregnancy? It is considered a serious global health and developmental issue. Now, nearly 111 million pregnancies each year in LMICs are unintended. That is almost half of all pregnancies. In sub-Saharan Africa, 1/3 are unintended. In South Asia, 1 in every 5 pregnancies is unintended. In Pakistan, this rate changes from 19 to 38% depending on which province we are. Generally, it's the highest in Balochistan and Sindh. In 2012 alone, there were 4.2 million unintended pregnancies. Over half ended in abortion and a third in unplanned births. Now, these unintended pregnancies, they carry steep consequences. On one hand, on one side, it's the maternal and neonatal risks, and on the other, it's driving the public costs for schooling, immunization, and water and sanitation. Globally, such costs reach billions of dollars every year. Yet, improved family planning access consistently saves money. In countries like Thailand and Ethiopia, each dollar spent saves more than 2 in health costs. In Pakistan, returns range from 2 to 5 USD saved per dollar invested, depending on which province we are talking about. Now, despite this, Pakistan National Finance Commission formula, this subject is frequently discussed at various forums, and in the earlier session at this conference, the panelist was also discussing the problem of the population as a major criteria for the NFC formula. Now, NFC formula allocates funds largely by population size. This often disincentivizes provincial investment in family planning. This tension between demographic pressure and fiscal design, this is at the heart of why this issue matters. So we set out to answer one key question, that is, what are the economic costs of unintended pregnancies in Pakistan, and how do family planning investments translate into healthcare savings, education expenditures, and broader social sectors. And our study objectives are to quantify, we are basically trying to answer these questions and fulfill our objectives, which are to quantify and project the economic costs of unintended pregnancies, evaluate the potential savings resulting from increased investment in family planning through a detailed cost-benefit analysis. The methodological framework we used to have this cost-benefit analysis was the Impact 2 model. We adapted it. This was originally by Mary Stopes International, and this framework estimates the family planning investment needed to avert unintended pregnancies and compares it to the costs that would otherwise fall on education, healthcare, and WASH. Using data, the baseline data from PDHS 2017-18 and some other national and international sources, we projected outcomes to 2035 and we adjusted it for inflation and applying a 23% discount rate to reflect the time value of money. Our results regarding unmet need and unintended pregnancies show that in 2018, a 17% unmet need led to 0.63 million unintended births each year. If unmet need declined by 0.5% annually, it reached 8.5% by 2035. Pakistan could reduce unintended pregnancies by 41%, averting 10 million cases. This directly contributes to lower under 5 mortality, falling from 69 to 39 per thousand by 2035. Regarding the CPR and births averted, raising CPR from 34% in 2018 to 57% by 2035, it could avert 3 million births per year. Cumulatively, that's near 38 million unintended pregnancies, resulting in live births prevented. It demonstrates how each percentage point increase in CPR yields exponential growth in economic gains. So finally, the economic cost or social cost of unintended pregnancies. The unintended pregnancies, as I already mentioned, it imposed a huge social cost in terms of in domains of education, health, and WASH. So we estimated that 1.7 billion USD was the social cost between 2018 to 2035 of these unintended pregnancies. Education and maternal health alone account for nearly 90% of this burden. Education costs double from 145 million USD to 309 million, while safe motherhood expenses rise from 91 million to 214 million. Now, if we invest in family planning, what would we save? So, to avert these pregnancies, we estimate that an FP, family planning investment of 67 USD translates into 1.55 billion of USD of savings, which is every $1 invested in family planning saves us $23 in these domains mentioned. That is savings distributed across health, education, WASH, and maternal care. Now, these results underline one central message, that is, family planning is both an economic necessity and a moral imperative. 3 policy priorities emerge. First is reforming fiscal incentives, which is revising the NFC award criteria. So provinces are rewarded for better health and FP outcomes, not population size. Second is the institutionalizing of the evidence. We need to establish a national family planning costing unit within the planning ministry to integrate family evidence into the budgeting. Third is scaling up the local innovations like the APRC initiative. This intervention is run by the sister organization of research and development solutions, which is Akhtar Hamid Khan Foundation. It's a community-led, low-cost model that have shown 3 to 5 times higher savings, and it also led to women empowerment. So closing, in my closing remarks, I'll just point out that family planning is not just a health intervention, it's a fiscal strategy for Pakistan's stability and growth. And by aligning fiscal reform, data-driven governance, and community innovation, Pakistan can turn this demographic challenge into a development opportunity. Thank you.
Thank you very much for making us wise on the issue that it is very good cost-benefit analysis, and I'm really impressed you wrote on this topic. Now I would like to invite Mr. Ayazuddin. He was member Census and Survey in Pakistan Bureau of Statistics, and he also was initial founder of Pakistan Demographic and Health Survey. The first survey was conducted by us, and we did the 4 rounds of PDHS. He would discuss the topics and give comments.
PSLM भी बनाया था ना हमने, तो हर चीज़ का कल्प्रिट मैं ही हूँ। तो थैंक यू सो मच, इट्स अ वंडरफुल प्रेजेंटेशन, आई रियली एंजॉयड इट। और मैं वैसे नहीं कह रहा, सीरियसली मुझे बहुत मज़ा आया देख के। द इम्पॉर्टेंट थिंग इज कि यू आर यूजिंग द डेटा। Actually, we have the data on our website, on PBS website, but no one is actually using it. And surprisingly, बहुत बड़ी universities को जब हम बात करते हैं, तो they don't know about this, what kind of data is available on PBS website. So, the other good news is that this highest PSLM is coming up, the latest round, 2024-25 जो है, which is also coming soon, inshallah, within a month time. और उसके अलावा we are also going to do a PDHS survey, which is integrated PDHS, PDS, Pakistan Demographic Survey, through which we actually calculate this growth rate of natural increase, and also PSLM. So it will also be a very good data set, but it will take some time. But inshallah, in a year time, you will also get this survey. So there are 4 topics actually. One was this CPR in Pakistan. The other was the client experience satisfaction, what women want for FP and unintended pregnancies. If you combine all these 4 topics ना, तो यही सब कुछ है. This is the issue. इसी में आपका solution भी है, इसी में आपका issue भी है. इसको understand करने की ज़रूरत है. अभी देखें कि आपका हमारा ये फरीद मदद साहब का था, मीटिंग भी होती थी, अदनान साहब भी थे हमारे साथ, आयशा, हम सब इसके इसी के मेंबर भी हैं, और उसमें ये इशू होता था क्राइसिस टू कोर्स करेक्शन। क्राइसिस टू कोर्स करेक्शन की जब हम बात करते हैं, व्हाट इज दैट? वो ये है कि वाई, अभी हम मैं सर से भी बात कर रहा था कि जब इंडिपेंडेंस हुई, देयर वर 3 लाइक बांग्लादेश, इंडिया एंड पाकिस्तान, दे हैव ऑल सेम TFR, बट व्हाट इज द सिचुएशन नाउ? बांग्लादेश, इंडिया TFR is 1.9, बांग्लादेश 2.0 एंड पाकिस्तान is 3.6. And CPR is India 56.4, और someone mentioned this कि अगर unintended pregnancies को अगर हम कर लें, डील कर लें, हैंडल कर लें, तो हम भी 57 पे पहुंच जाते हैं। तो it means कि we are lacking somewhere in planning. हमारी प्लानिंग में बहुत बड़ा इशू है जिससे हमें काउंटर करना है। अदरवाइज ये जो चीज़ है ना कि हम जितने भी आप इकोनॉमिक डेवलपमेंट आप जितनी भी कर लेंगे ना, इट विल गोइंग टू ईट अप योर पॉपुलेशन। ऑन मैनी फोरम्स, बहुत हाई फोरम्स पे, ऐसी जगहों पे कि जहाँ लोग बहुत बेटर करते हैं, वहाँ डिस्कशन सब होती है, दे ओनली टॉक अबाउट द इकोनॉमिक ग्रोथ, और ये कि हम ये कर दें, ये डेवलपमेंट हो जाए, ऐसे हो जाए, वैसे हो जाए, लेकिन दे डोंट कंसिडर दिस पॉपुलेशन इशू कि अगर पॉपुलेशन 2.55 ग्रोथ रेट से अगर इंक्रीज कर रही है, तो इट विल गोइंग टू ईट अप एवरीथिंग। आप जो मर्जी कर लें, आपका इशू वहीं का वहीं रह जाएगा। तो ये सबसे बड़ा आपका इशू ये है। दूसरा ये कि ये जैसे अभी क्लाइंट सेटिस्फेक्शन की बात करें, तो वे इन डेप्थ एक्चुअली वी हैव डन 2 सर्वेस। वन वाज अबाउट द चॉइस ऑफ मेथड एंड द अदर वाज अबाउट द क्वालिटी ऑफ सर्विसेज एंड सिचुएशन एनालिसिस बाय द फैमिली वेलफेयर सेंटर्स। चॉइस ऑफ मेथड्स में द फर्स्ट चॉइस वाज जो women ने select किया, only 30% continued and 70% dropped out because there was no follow-up. In case of their side effects, there are no medicines available. And the about the staff in the family welfare center, there were male motivator and a chowkidar sitting there, so there is no privacy. Only 70% had this, 70% of the women don't have this visual privacy. So there are so many factors actually which are playing their role that our CPR is not increasing. There will be no magic that overnight we can increase our CPR by pumping money or doing something else. Until unless we correct our things at the basic level, we will not be able to achieve our goals. So I'm not going to take much time, लेकिन ये जो है अनइंटेंडेड प्रेगनेंसीज, वो भी था, एक सिंपोजियम भी हुआ था, उसमें भी था कि 4 जो मिलियन है, जो आपने फिगर यहाँ कोट किए, 4.2 मिलियन जो है अगर आप अवॉइड करते हैं, तो आप भी देखिए कि आप अभी आपका जो मैटरनल मोर्टालिटी रेट है, इज द हाईएस्ट इन वन ऑफ द हाईएस्ट इन द वर्ल्ड, इज 186। सो अगर ये चीज़ें अगर आप करेंगे तो बाकी चीज़ें भी ऑटोमेटिकली ठीक होती हैं। जब तक आप इन चीज़ों को काउंटर नहीं करेंगे, آپ پلاننگ کے ہمارا مسئلہ یہ ہے کہ آپ کی اتنی اچھی ریسرچ جو ہے کیا یہ پلاننگ میں شیئر ہوتی ہے, کیا پلاننگ میں سے کوئی امپلیمنٹ کرتا ہے؟ اصل ایشو یہ ہے کہ جب تک ہماری ریسرچ ہماری چیزیں گورنمنٹ اون نہیں کرتی اور جب تک اس کو اپنی پلاننگ میں نہیں لے کے آتی اس کا کوئی فائدہ نہیں ہوتا. لیکن اس کا مطلب یہ نہیں کہ آپ ریسرچ کرنا چھوڑ دیں, لیکن میرا کہنے کا مقصد یہ ہے کہ ہماری انٹریکشن جو ہے ایٹ آل لیولز بہت زیادہ ہونی چاہیے. ہمارا بھی ایک سب سے بڑی ٹریجڈی ہوئی کہ ہم نے اس کو پروونشل سبجیکٹ بنا دیا. کبھی یہ پولیٹیکل گیم ہو جاتا ہے کہ آپ کا کیا ہوتا ہے کہ جی وہ گورنمنٹ ٹاپلز ہو رہی ہیں اس بیس پہ کہ جی کہیں گورنمنٹ ٹاپلز ہو گئی کہ جی وہ جو ہے یہ فیملی پلاننگ کو پروموٹ کر رہے ہیں اور پڑھے لکھے لوگ اس میں شامل ہو گئے صرف کسی کی گورنمنٹ گرانے کے لیے. اس کی وجہ سے کیا ہوا کہ دنیا آگے نکل گئی, ہم پیچھے رہ گئے. ابھی بھی اٹس نیور ٹو لیٹ, اسٹل وی ہیو اے ٹائم کہ ہم اگر کسی اسٹیج پہ بھی اپنے آپ کو ٹھیک کرتے ہیں تو ہم وی کین کیچ اپ ود دی ادر کنٹریز. لیکن اس کے لیے ہماری پولیٹیکل کمٹمنٹ بہت اسٹرانگ ہونی چاہیے, نیگیٹو نہیں پازیٹیو بہت زیادہ اسٹرانگ ہونی چاہیے. اس کے علاوہ ہماری سپلائیز بہت آفٹر یہ ابھی ریسنٹلی جو ہماری ایک کانٹرسیپٹیو بنتی ہے رپورٹ, ہماری کانٹرسیپٹیو پرفارمنس رپورٹ, اس میں جو آپ کا ماڈرن سی پی آر ہے وہ 41 آ رہا ہے اور آپ کا پی ڈی ایچ ایس رپورٹ کر رہا ہے 24%. تو سی اٹ مینس کہ وائی دیر از اے گیپ. اب جب آپ وہ کوئی سروے کرتے ہیں تو آپ کو پتہ چلتا ہے کہ جی وہاں پہ تو سپلائیز ہی نہیں ہے, وہاں پہ کوئی چیزیں نہیں ہیں. تو اٹ مینس کہ جو بیچارے لوگ جاتے بھی ہیں آپ کو یوز کرنے کے لیے, اگر ان کو سائڈ افیکٹ, اچھا سب سے بڑا ریزن یہ ہوتا ہے کہ وائی دے ڈسکنٹینیو. دا ون از دیٹ دی سائڈ افیکٹس اینڈ ادر از دا فیلئر آف دا میتھڈ. اب دس از دا اسٹرینج تھنگ نا کہ فیلئر آف میتھڈ بھی ہے کوئی اور اس کو کوئی دیکھنے والا نہیں ہے کہ نو ون از دیئر ٹو ایڈریس دس ایشو کہ جی اس کو کیسے اس کو کیا جائے, کیا کیا جائے, اینڈ دیر از نو چیک اینڈ بیلنس. جب اگر وہاں پہ ہمارا سروے تھا چوائس آف اس کا کوالٹی آف سروسز کا 28% clients were only traceable and there was so just think about this کہ آپ کا 70% کے قریب bogus reporting ہے. تو وہ یہ جو چیزیں امپیکٹ ہیں یہ آپ کو جب تک ہم اس کو نہیں ہینڈل کرتے تو آپ کی کورس کریکشن ہو نہیں سکتا. آپ کا صرف پیسہ لگانے سے ان چیزوں سے کچھ نہیں ہو سکتا. پرائیویٹ سیکٹر کو انکریج کرنا بہت ضروری ہے. فیڈرل لیول پہ فیڈرل اس کی سپرویژن بہت ضروری ہے جو کہ ختم ہو گئی ہے. پروونسز کی کوارڈینیشن نہیں ہے, اوپر سے سپرویژن باڈی کوئی نہیں ہے. اور جب تک ہم یہ سارا سسٹم ان پلیس نہیں کرتے میرا نہیں خیال کہ ہم جو مرضی کر لیں ہم کو اچھے ریزلٹس لا سکتے ہیں. تو ود دس میرے خیال میں ٹائم بھی کافی ہو گیا. آئی ووڈ لائک ٹو کنکلوڈ ہیئر.
So I think that papers are very much self-explanatory, so though no questions are required.
تو سندھ کے ایکسپیرینس کو ہی لے کے بھی ہے اسکیل اپ ٹو نیشنل لیول دس پروڈکٹ. یا
It is an interesting research. Now I would like to invite Dr. Grace to give her comments on the papers and she might suggest some course correction for this topic of our conference.
Thank you. The first thing I'd like to say is that whatever else Pakistan has a shortage of, it doesn't have a shortage of brilliant young researchers. And so that's very reassuring, I think, and really speaks well to the future. Now, the particular things, I thought that the data analysis was brilliant, and I enjoyed it. I actually enjoyed it. You have to be a little funny to really get excited about, but I did. It was good. But the more important part you raised is that it can help government to target. When resources are short, you can't do everybody. The piece on shots I thought was also wonderful because it was a good example of the kind of demonstration that can go to the targeted areas, and so we can see results and hopefully. I think it's always wonderful when we listen to the people that we're going to make policy for. I mean, in addition to being an academic, I was a bureaucrat for 30 years. So, in policy. So one of the challenges is always, not what all the politicians think, not what all the businessmen think, not what all the rich people think. What do the people think who really are going to get the services? And so I thought that was wonderful. So thank you for that. And then these days when I'm in the US, I teach in Hopkins Business School, so return on investment is always a big deal. And I think for many of the politicians, rich people, businessmen, that's an argument they understand. And so it's important for us trying to do something wonderful to help women. It's important for us to be able to speak to people in languages that they understand so that we can get their support, get them to follow, because in this conference, wonderful presentations are being given. Everybody's talking about the problem is actually getting the policy and getting it implemented. So, thank you all. You did a wonderful job, and I really appreciate being here to listen to you. Thank you.
Thank you very much for your encouraging comments. I also congratulate all the presenters and all the participants who have taken their interest and attended our session. But I would like to add one thing. I did 4 rounds of Pakistan demographic and health surveys, and Mr. Ayaz also said that data is not being used. So I just joined Health Services Academy as a public health teacher, professor, and if anybody would like to do some research on data, I can help them, and we would like to have some more topics because we have more than 90 students in 2 sessions, and they are just searching for the topics and they can't think about any very innovative project for their PhDs. So you would anybody like to consult me or interact with me, you are more than welcome. Thank you very much. Thank you to all for joining this session.